So good afternoon, everyone. My name is Jason Liu. I am the current PGY2 Emergency Medicine Pharmacy resident at the University of Vermont Medical Center. And today I'll be presenting on drawing the line for adrenaline. Epinephrine remains the first-line adrenergic agent for patients in cardiac arrest. The current recommended dose of 1 milligram for adults was derived from the 1960s and remain a mainstay for our ACLS algorithm today. Initial studies in the 60s showed that epinephrine improved survival in animal models and established a dose of epinephrine 1 milligram. However, these studies was conducted in 10 to 30 kilogram dogs, which makes us question how translatable these studies are to humans, given the major difference in pathophysiology and pharmacokinetics. Despite controversies, epinephrine remains a mainstay in cardiopulmonary resuscitation, mimicking the doses used in the first canine models. Few studies in humans assess the different effectiveness and the corrective dose used in the treatment of cardiac arrest. A study by Friss et al. Looked at whether the 1 milligram IV epinephrine dose compared to low dose epinephrine at 0.5 will have a difference on survival to discharge and improved neurologic outcomes in non-traumatic out-of-hospital cardiac arrest. It was concluded that low-dose epinephrine neither improved survival to hospital discharge or favorable neurologic outcomes. Some might argue, why change from the 1 milligram then? Here are some reasons. An observational study conducted in 2014 assessed the impacts on epinephrine on outcomes of all patients with out-of-hospital cardiac arrest. Epinephrine was used as either being used, absent, or by dose at 1 milligram, 2 to 5 milligrams, and greater than 5 cumulative doses. They noticed that high-dose epinephrine was associated with worse neurologic outcomes. Some of you thinking are that if the patient codes longer, they're going to get more epi. So another recent study in 2021 that looked at epinephrine doses during cardiac arrest and 3-month neurologic function among cohort patients that underwent cardiac arrest. These authors adjusted for the time of ROSC, ICU stay, previous neurologic disease, and witnessed cardiac arrest, bystander CPR, and other. In the fully adjusted model, which you see in blue, the results indicates that the patients who received more than 5 milligrams of epinephrine were 60% less likely to achieve a favorable neurologic outcomes than those that received less than 2. The association between epinephrine accumulative doses and poor neurologic outcomes, those who survive cardiac arrest, have demonstrated in observational studies. Since we have a cohort study that shows that there was no difference between the 1 milligram compared to the 0.5 in regards to hospital discharge or favorable neurologic outcomes, should we be considering a lower dose of epi to see if this will be moving towards patients having more favorable neurologic outcomes? While I understand these are not randomized controlled trials, if you want to stick with animal models like the original canine study, Giuseppe et al. In 2009 published a research on domesticated pigs showed that epinephrine actually had adverse effects on cerebral microvascular blood flow, which increases the severity of cerebral ischemia during CPR. In 2018, we had a large randomized controlled trial of epinephrine for out-of-hospital cardiac arrest that was published, called the PharmD 2. In this study, they found that patients had an increased chance of return of spontaneous circulation, increase in 30-day survival. At face value, these seems like great outcomes for patients. But when we consider the facts of this case, patients were not walking out of the hospital, since the patient had more severe neurologic outcomes. So if we take the numbers from the PharmD 2 trial, for every 1,000 patient that comes in for a hospital cardiac arrest, there will be 8 survivors at 30 days. Out of those 8 survivors, 3 will have good neurologic outcome and 5 will have bad outcomes. As resuscitation intervention has become more successful, there's an increased need to reconsider the patient-centered outcomes, such as functional status and quality of life, in addition to greater likelihood of ROSC The early potential benefit of heart does not guarantee good patient outcomes, as patients are resuscitated from cardiac arrest, might have neurologic impairment and a decreased quality of life. The time to epinephrine is still not known. The recommendation suggests epinephrine administered every 3 to 5 minutes. A practical approach that we use is a fixed at 4 minutes administration interval that allows providers to synchronize it between the 2 minutes of chest compressions, rhythm checks, and defibrillations. This recommendation falls from the half-life of epinephrine, and there are few clinical data about epinephrine administration intervals. One was a retrospective review in 2017 in PEDS, which found that ROS and survival was better with epi administered between 5 to 8 minutes and better between 8 to 10 minutes compared to the 1 to 5 minute interval. The authors concluded that less epinephrine with less frequency was associated with better outcomes. Another study in 2021 in PEDS actually found more frequent doses, less than 2 minute intervals, were associated with better outcomes. Perhaps there's not one single epinephrine administration interval that is best for all resuscitations. And investigators should focus on developing a personalized and responsive approach based on the physiological feedback and adapt to the situation and condition of the patient that's in front of them. Although the administration of epinephrine remains one of the most common ACLS interventions and likely increases the rate of ROS after cardiac arrest, its effects on long-term outcomes is far less certain. While further studies of epinephrine are needed in regards to the unproven standard of care that we do of epinephrine, it remains unclear the optimal dose and frequency of epinephrine to increase neurologic intact survival. Thank you so much for your time.